In good health, a delicate balance of fluids, electrolytes, and acids and bases is maintained in the body. This balance, or fluids and electrolytes, are the basic elements of life. All chemical reactions within the body take place in fluids. Electrolytes react because they have electrical charge, negative or positive. The primary fluid of the body is water. It comprises 70% of living cells and 60% of an average adult body's weight. An average healthy person needs about 2 to 2.5 liters of water per day to meet the body's fluid requirements. Most adults produce about 1,500 milliliters of urine per day. Additional fluids are lost during illness through insensible fluid loss, water that passes through the skin and from the respiratory tract and is lost by the evaporation or with fever, wound drainage, vomitus, or diarrhea. There are two body compartments, the intracellular fluid ICF compartment and the extracellular fluid ECF compartment. The ICF consists of fluid that exists within the cell's cytoplasm and nucleus. The ECF consists of fluid that exists outside the cell, such as interstitial fluid between the cells, fluid in the bloodstream or serum, cerebral spinal fluid, better known as CSF, in the central nervous system, gastrointestinal secretions, sweat, and urine. Two-thirds of the body's water is in the ICF, and one-third is in the ECF. Only 5% of body fluid is normally in the blood. Body fluids control and assist many body functions. For example, enzymes in saliva and mucus assist the passage of food into the stomach and provide mechanisms for hydrolyzing food into elements the body can absorb. ECF in the blood and CSF serve as transport mechanisms to deliver electrolytes, oxygen, and nutrients and hormones to tissues. Body fluids also carry immune system cells to injury sites for the body's defense. ECF eliminates the body's waste products through the kidneys, bowel, and perspiration. Body functions depend on fluid facilitating the movement of electrolytes from one body compartment to another, often multiple times per minute, to affect electrochemical action such as the heartbeat, secretion of a hormone, or a neuromuscular transmission. Another vital function of ECF is the regulation of body temperature through perspiration and capillary dilatation to give off excess heat or conserve heat through the skin. Body fluids are regulated by osmosis, diffusion, and filtration. Osmosis is based on the relationship of the molecules of solute, electrolytes, to water molecules. Relationship refers to the presence or correlation of ions or electrolytes to water. In osmosis, the ions move from dilute concentration to heavily concentrated liquid of concentrated solutions, or light to heavy. Diffusion depends on size of molecules, electrical charges, and pressure gradient. An elevated pressure gradient resists the transfer of elements into lower pressure area. Filtration takes place when molecules from an area of higher concentration move through permeable membranes to an area of lower concentration as a result of hydrostatic pressure. Hydrostatic pressure is the pressure exerted on the surrounding tissues because of presence of water. Filtration occurs in the body because of hydrostatic pressure generated by the pumping action of the heart. On the arterial side of the capillary, the hydrostatic pressure is 32 millimeters of mercury. On the venous side of the capillary, the hydrostatic pressure is 15 millimeters of mercury. This favors movement of fluids from the bloodstream into the tissues on the arterial side of the capillary and back into the bloodstream on the venous side of the capillary after the fluid filter through the tissues and bathes cells in the interstitial fluid. Oncotic pressure, also known as colloidal osmotic pressure, is osmotic pressure exerted by colloids in solution. The major colloid in the vascular system contributing to the total osmotic pressure is protein. Protein molecules attract water, pulling fluid from the tissue space to the vascular space. Under normal conditions, plasma oncotic pressure is approximately 25 millimeters of mercury. Blood pressure is an example of hydrostatic filtering force. It moves whole blood from the heart to capillaries where filtration can occur to exchange water, nutrients, and waste products between the blood and the tissues. One factor that determines whether fluid leaves the blood vessels and enters the tissue space, or interstitial fluid, is the difference between hydrostatic pressure of the capillary blood and that of the interstitial fluid. Edema is an abnormal accumulation of fluid in the organs, body cavities, or extremities. It develops when increased hydrostatic pressure, or pushing pressure, forces fluids out of the arterial end of the capillaries and into the tissues, and decreases oncotic pressure, or pulling pressure, from drawing fluid back into the venous end of the capillaries. There are different types of edema. Anasarca means generalized edema of the body. Ascites is the accumulation of excess fluid in the peritoneal cavity. Cerebral edema is an accumulation of excess fluid in the brain. Lymphedema is swelling causing by blockage of the lymph vessels that drain fluid from the tissues throughout the body. Periorbital edema is swelling around the eyes. Peripheral edema is swelling of the extremities, usually the legs. Pleural effusion is the accumulation of fluid in the pleural sac that surrounds the lung. Pulmonary edema is the accumulation of fluid in the lung. Diffusion is the free movement of particles, solute, across a permeable membrane from an area of higher concentration to an area of lower concentration. A concentration gradient exists when two fluid spaces have different amounts of the same type of particles. The speed of diffusion is related to the difference in the amount of particles, concentration gradient, between the two sides of the membrane. The degree of difference is the steepness of the gradient. The larger the concentration difference between the two sides, the steeper the gradient. Diffusion is more rapid when the gradient is steeper. Particles move from the fluid space with a high concentration of solute particles to fluid space with a lower concentration of solute particles. Diffusion is important in the transport of most electrolytes and other particles through cell membranes. Cell membranes are selective in which particles can diffuse. Some particles cannot move across the cell membrane because membranes are impermeable, not open to the particle. Impermeability and special transport systems cause differences in the amount of specific particles from one fluid space to another. For example, usually fluid outside the cell, better known as ECF, has 10 times more sodium ions than the fluid inside the cell, or ICF. This extreme difference is caused by cell membrane impermeability to sodium and by special sodium pumps that move any extra sodium present inside the cell out of the cell against its concentration gradient and back into the ECF. In some instances, diffusion cannot occur without help because of selective permeability. One example is glucose. Even though the amount of glucose may be much higher in ECF than in ICF, glucose cannot cross most cell membranes without the help of insulin. When insulin is present, it binds to insulin receptors on cell membranes, which then makes the membranes much more permeable to glucose. Diffusion across the cell membrane that requires the assistance of a membrane-altering system, such as insulin, is called facilitated diffusion or facilitated transport. This type of movement is still a form of diffusion. Osmosis and filtration act together at the capillary membrane to maintain both ECF and ICF volumes within normal ranges. The thirst mechanism is an example of how osmosis helps maintain homeostasis. The feeling of thirst is caused by the activation of cells in the brain that respond to changes in ECF osmolarity. These cells are so sensitive to changes in ECF osmolarity that they are called osmoreceptors. When a person loses body water, but most of the particles remain, such as through excessive sweating, ECF volume is decreased and osmolarity is increased. A hypertonic condition exists. The cells in the thirst center shrink as water moves from the cells into hypertonic ECF. The shrinking of these cells triggers a person's awareness of thirst and increases the awareness to drink. Drinking replaces the amount of water lost through sweat and dilutes the ECF osmolarity, restoring it to normal. It is important to remember that the thirst mechanism is less sensitive in older adults, making them more at risk for dehydration. Fluid balance is closely linked and affected by electrolyte concentrations, a person's age, gender, amount of body fat affect the amount and distribution of body fluids. An older adult has less total body water than a younger adult. An obese person has less total body water than a lean person of the same weight because fat cells contain almost no water. Body fluids are constantly filtered and replaced as fluid balance is maintained through I&O. The total amount of water within each fluid space is stable, but individual water molecules move continuously among all spaces. Fluid intake is regulated through the thirst drive. Fluids enter the body mainly as liquids. Solid foods also contain about 85% water, allowing some fluid to enter the body with ingested solid foods. Fluid loss occurs through several routes. Of all the water loss pathways, the kidneys are the most important and the most sensitive. Water loss by the kidneys is regulated and is adjustable. The volume of urine excreted daily varies depending on the amount of fluid taken in and the body's need to conserve fluids. The minimum amount of urine per day needed to excrete toxic waste products is somewhere between 400 to 600 milliliters. If urine output for 24 hours falls below the obligatory urine output amount, wastes are retained and can cause lethal electrolyte imbalances, acidosis, and toxic buildup of nitrogen. Other normal water loss occurs through the skin, the lungs, and the intestinal tract. Water loss from the skin, lungs, and stool is called insensible water loss because the body has no mechanism to control this loss. The amount lost can be significant. In a healthy adult, insensible water loss is between 500 to 1,000 milliliters per day. Insensible water loss also increases when the environment is hot and dry. Insensible water loss, if not balanced by intake, can lead to severe dehydration and electrolyte imbalance. Aldosterone is a hormone secreted by the adrenal gland whenever sodium levels in the ECF are decreased. Aldosterone prevents both water and sodium loss. When aldosterone is secreted, it acts on the kidney's nephrons, triggering them to reabsorb sodium and water from urine back into the blood. ADH released from the pituitary gland is controlled by the hypothalamus in response to changes in blood osmolarity. Increased blood osmolarity, especially an increase in the level of plasma sodium, results in a slightly shrinkage of these cells and triggers ADH release from the pituitary. ADH acts directly on the kidney tubules and collecting ducts, making them permeable to water. As a result, more water is reabsorbed by the tubules and returned to the blood, decreasing blood osmolarity and making it more dilute. When blood osmolarity decreases, especially when the plasma sodium level is below normal, the osmoreceptors swell slightly and inhibit ADH release. Less water then is reabsorbed and more is lost from the body in the urine. As a result, the amount of water in ECF decreases, bringing osmolarity up to normal. Nucleic peptides are hormones secreted by specialized cells that line the atria and the ventricles of the heart. These peptides are secreted in response to increased blood volume and blood pressure, which stretch the heart tissue. Nucleic peptides bind to receptors in the nephrons, creating effects that are opposite of aldosterone. Kidney reabsorption of sodium is inhibited at the same time the glomerular filtration in the kidneys is increased, causing urine output. The outcome is decreased circulating blood volume and decreased blood osmolarity. The human body requires a balance of body fluids, electrolytes, and acids and bases for best function. The most important to keep in balance are the blood volume and the ICF. Of these two, the most critical fluid balance to prevent death is maintaining blood volume at a sufficient level for blood pressure to remain high enough to ensure adequate perfusion and oxygenation of all organs and tissues. Balance of both water and electrolytes is needed for this very vital function. Because the kidney is a major regulator of water and sodium balance to maintain blood pressure and perfusion to all tissue and organs, the kidney monitors the blood pressure, blood volume, blood oxygen level, blood osmolarity levels. When the kidney senses that any of these parameters is getting low, they begin to secrete a substance called renin that sets into motion a group of hormonal and blood vessel responses to ensure that the blood pressure is raised back to normal. Triggering events include a low blood pressure, low blood volume, low blood oxygen level, and low blood sodium because sodium and water are closely linked. Where sodium goes, water follows. So anything that causes the blood to have too little sodium prevents water from staying in the blood. Once the kidneys sense that tissues and organ perfusion are at risk, special cells in the nephron begin to secrete renin into the bloodstream. Renin is an enzyme that activates some blood proteins, one of which is angiotensinogen. Activated angiotensinogen is angiotensin 1, which is a relatively weak and has little action. It is then acted on by another enzyme known as angiotensin converting enzyme or ACE, which converts angiotensin 1 into its most active form, angiotensin 2. Angiotensin II starts several different activities that all work to increase blood volume and BP. It is a powerful vasoconstrictor. It causes constriction of small arteries and veins throughout the body. At the same time, a second action of angiotensin II is that it constricts the size of arterioles that feed the kidney nephrons. This action results in a huge reduction in urine output. Decreasing urine output prevents further loss of water, so more is retained in the blood to help raise blood pressure. The last and slightly slower action of angiotensin II is to cause the adrenal glands to secrete the hormone aldosterone. Aldosterone is nicknamed the water and sodium saving hormone because it causes the kidneys to reabsorb water and sodium, preventing them from being excreted into the urine. The renin-angiotensin II pathway is greatly stimulated whenever the patient is in shock or is stressed to the point that the stress response is stimulated. This is why urine output is used as an indicator of perfusion adequacy after surgery or any time a patient has undergone an invasive procedure. An additional application of this pathway is related to management of hypertension. Patients who are hypertensive are often asked to limit their sodium intake. The reason for this is that a high sodium intake raises the blood level of sodium, causing more water to be retained in the blood volume and raising blood pressure. Drug therapy for hypertension may include diuretic drugs that increase the excretion of sodium so that less is present in the blood, resulting in lower blood volume. Another class of drugs often used to manage blood pressure are the ACE inhibitors. These drugs disrupt the renin-angiotensin II pathway by reducing the amount of angiotensin-converting enzymes, or ACE, made so that less angiotensin II is present. When less angiotensin II, there is less vasoconstriction and reduced peripheral resistance, less aldosterone production, and greater excretion of water and sodium in the urine. In dehydration, fluid intake or fluid retention is less than is needed to meet the body's fluid needs, resulting in a fluid volume deficit, especially a plasma volume deficit. It is a condition rather than a disease, and it can be caused by many factors such as hemorrhage, vomiting, diarrhea, profuse diaphoresis, burns, long-term NPO status, diuretic therapy, GI suction, unconsciousness, and fever. Dehydration may be an actual decrease in body water caused by either too little intake of fluid or too great a loss of fluid. It can also occur without an actual loss of total body water, such as when water shifts from the plasma into the interstitial space. Dehydration may occur with just water loss or with water and electrolyte loss. Isotonic dehydration is the most common type of fluid loss problem. Fluid is lost only from the ECF space, including both plasma and interstitial spaces. There is no shift of fluid between spaces, so ICF fluid remains normal. Circulating blood volume is decreased and leads to inadequate tissue perfusion. The body's defense adapt during dehydration to maintain adequate flow to vital organs in spite of hypovolemia. Mild dehydration is very common among healthy adults and is corrected or prevented easily by matching fluid intake with fluid output. Problems occur when people perform heavy exercise, especially in warm environments, without taking the time to replace excessive fluid losses. Dry climates and higher altitudes also increase fluid loss through the respiratory tract. Teach all patients to drink more fluids, especially water, whenever engaged in heavy physical activity or live in dry climates or in high altitudes. Moderate to severe dehydration is more likely to occur in people who are unable to obtain fluids without help. Older adults living in long-term care facilities and those adults with cognitive or motor problems depend on others for hydration. Offering fluids every 1 to 2 hours to these individuals can prevent dehydration. Nearly all body systems are affected by dehydration to some degree. The most obvious changes occur in the cardiovascular and integumentary systems. Cardiovascular changes are good indicators of hydration status because of the relationship of plasma fluid volume and blood pressure. Heart rate increases in an attempt to maintain blood pressure with less blood volume. Peripheral pulses are weak, difficult to find, and is easily blocked with light pressure. Blood pressure decreases. The blood pressure with the patient standing may be much lower than in other positions. As the blood pressure changes with position changes, the patient may not have sufficient blood flow to the brain, causing sensations of lightheadedness and dizziness. The problem increases the risk for falling, especially among older adults. Respiratory changes include an increased rate because the decreased blood volume reduces perfusion and oxygenation. The increased respiratory rate is an attempt to maintain oxygen delivery when perfusion is decreased. Skin changes can indicate dehydration. Assess the skin and mucous membranes for color, moisture, and turgor. In older adults, skin changes are less reliable because of poor skin turgor from loss of elastic tissue and increased skin dryness from loss of tissue fluids with normal aging. Neurologic changes include alterations of mental status and body temperature because blood flow to the brain is reduced. Mental changes, especially confusion, are more common among the older adult and may be the first indication of a fluid balance problem. The patient with dehydration often have low-grade fever, and a fever can also cause dehydration. A patient with a temperature higher than 102 degrees Fahrenheit longer than 6 hours is at risk because increased body temperature increases the rate at which fluids are lost. Renal or kidney changes in dehydration affect urine volume and composition. Monitor urine output, comparing total output with total fluid intake and daily weights. The urine may be concentrated with a specific gravity greater than 1.030. The urine color is dark amber and has a strong odor. Collect specific information about output because exact intake and output volumes are important, as are serial daily weight measurements. 1 liter of water weighs 1 kilogram or 2.2 pounds. Changes in daily weight are the best indicators of fluid losses or gains. A weight change of 1 pound corresponds to a fluid change of about 500 milliliters. Urine output below 500 milliliters per day for any patient without kidney disease is cause for concern. Weigh the patient at the same time and on the same scale. No single laboratory test confirms or rules out dehydration. Dehydration is determined by laboratory findings along with clinical manifestations. Usually, laboratory findings with dehydration show elevated levels of hemoglobin, hematocrit, serum osmolarity, glucose, protein, blood urea nitrogen, and various electrolytes because the more water lost and other substances remain, which increases the osmolarity or concentration of the blood, better known as hemoconcentration. Hemoconcentration is not present when dehydration is caused by hemorrhage because loss of blood and plasma products occur together. As nurses, our focus in managing a patient with dehydration is to prevent injury, prevent further fluid losses, and increase fluid compartment volumes to normal ranges. So our nursing priorities include patient safety, fluid replacement, and drug therapy in our plan of care. Patient safety issues and strategies are priorities of care before and during other therapies for dehydration. The patient with dehydration is at risk for falls because of the accompanying orthostatic hypotension, dysrhythmias, muscle weaknesses, and possible confusion. Assess for muscle strength, gait stability, and level of alertness. Instruct the patient to get up slowly from a lying or sitting position and to immediately sit down if he or she feels lightheaded. Implement fall precautions. Fluid replacement is key to correcting dehydration and preventing death from reduced perfusion. Mild to moderate dehydration is corrected with oral fluid replacement if the patient is alert enough to swallow and can tolerate oral fluids. Provide fluids the patient enjoys and carefully time the intake schedule. Dividing by nursing shifts the total amount of fluids helps meet the fluid needs more evenly over 24 hours with less dangers of overload. Coordinate with unlicensed assistive personnel to meet specific fluid needs. Teach unlicensed assisted personnel to offer 2 to 4 ounces of fluid every hour to patients who are dehydrated or who are at risk for dehydration. Instruct them to stay with the patient while they drink the fluid and note the exact amount ingested. Direct the unlicensed assistive personnel to report any difficulties the patient may have in swallowing or managing the fluids. Oral rehydration therapy is a cost-effective way to replace fluids. These are more often used in home settings, in long-term care, and for patients who have poor veins, making IV therapy difficult. Avail- Available oral rehydration therapy solutions for adults include Equalyte, Oralite, and Rehydrate Light. Drug therapy for rehydration is directed at restoring fluid balance and controlling the cause of dehydration. Whenever possible, fluids are replaced orally. When dehydration is severe or life-threatening, or the patient cannot tolerate oral fluids, IV fluid replacement is needed. Calculation of how much fluid to replace is based on the patient's weight loss and clinical manifestations. The rate of fluid replacement depends on the degree of dehydration and the presence of other heart, lung, or kidney problems. Drug therapy may correct some causes of dehydration. For example, antidiarrheal drugs prescribed when diarrhea causes dehydration. Antimicrobial therapy may be used in patients with bacterial diarrhea. Antiemetics may be used when vomiting causes dehydration. Antipyretics to reduce fever are helpful when fever makes dehydration worse. Fluid overload, also called overhydration, is an excess of body fluids. It is not a disease, but rather a clinical sign of a problem in which fluid intake or retention is greater than the body's fluid needs. Fluid overload may be either an actual excess of total body fluid or a relative fluid excess. Patients with fluid overload often have pitting edema. Other manifestations are usually seen in the cardiovascular, respiratory, neuromuscular, integumentary, and GI systems. Cardiovascular changes include increased pulse rate, bounding pulse quality, full peripheral pulses, elevated blood pressure, distended hand and neck veins, and weight gain. Respiratory changes include increased respiratory rate, shallow respirations, increased dyspnea with exertion, or in the supine position, and moist crackles on auscultation. Skin and mucous membrane changes may manifest as pitting edema in dependent areas, skin pale and cool to touch. Neuromuscular changes include altered level of consciousness, headache, visual disturbances, skeletal muscle weakness, and paresthesis. Gastrointestinal changes include increased motility and enlarged liver. Fluid overload is diagnosed based on assessment findings and the results of laboratory tests. Usually, serum electrolyte values are normal, but decreased hemoglobin and hematocrit, as well as serum protein levels, may result from excessive water in the vascular space or hemodilution. The focus of our nursing interventions for patients with fluid overload is to ensure patient safety, restore normal fluid balance, provide supportive care until the imbalance is resolved, and prevent further fluid overload. Drug therapy, nutrition therapy, and monitoring intake, output, and daily weights are the interventions. Patient safety is the number one priority. Interventions are implemented to prevent fluid overload from worsening, leading to pulmonary edema and heart failure. Monitor for indicators of increased fluid overload with bounding pulses, neck vein distension, crackles in the lung, increased peripheral edema, weight gain, and reduced urine output. The patient with fluid overload is at risk for skin breakdown. Use a pressure reducing or pressure relieving overlay on the mattress. Assess skin pressure areas daily for signs of redness or open areas, especially on the coccyx, the elbows, the hips, and the heels. Help the patient change positions every 2 hours or ensure that the unlicensed assisted personnel perform that action. Drug therapy focuses on removing excess fluids. Diuretics are prescribed for fluid overload if kidney failure is not the cause. These drugs increase the kidney water and sodium excretion. Loop diuretics, such as furosemide or Lasix, monitor the patients for response to drug therapy, especially weight loss and increased urine output. Observe for manifestations of electrolyte imbalance, especially changes in the electrocardiogram patterns. Assess laboratory findings, especially potassium and sodium. Nutrition therapy for the patient with chronic fluid overload may involve restrictions of both fluid and sodium intake to control fluid volume. Often sodium restrictions involves only no added salt to ordinary table food when fluid overload is mild. For severe fluid overload, the patient may be restricted to 2 to 4 grams per day of sodium. If sodium restriction is ongoing, teach the patient and the family to check food labels for sodium content and how to keep a daily record of sodium ingested. Explain the reason for any fluid restriction and the importance of adhering to prescribed restrictions. Monitor intake, output, and weight provides information of therapy effectiveness. Fluid retention may not be visible. Remember that rapid weight gain is the best indicator of fluid retention and overload. After the patient is discharged, teach the patient and the family to monitor weight at home. Suggest that a record of daily weights be kept to show the healthcare provider at checkups. Also instruct the patient to call the healthcare provider for more than a 3-pound gain in a week or more than a 2-pound weight gain in a 24-hour period of time.